That's a beautiful view setup. So anyway, so I think the time at 12 o'clock, I would like to introduce our speaker for today, and then we start the presentation. And so we have two speakers that have done it before, both experienced proton expert and also experience in use of DIBH for retro for treatment of moving tumor. We have Dr. Arpit Chhabra is attending resident oncologist at the New York Proton Center, and Dr. Chhabra have been there for many years, and he practiced his specialty in the GI, also in the basic skull spine area. He's a director of education, and he's a lead physician in the international relation program at the center. And he have extensive training in proton at UC Maryland, also the fellowship there. So he also published extensively many papers, textbook chapter, and use of proton therapy. And the second speaker is Dr. Haibo Lin. He's a chief physicist of proton at the center. And Dr. Lin have trained at UC Pennsylvania, and he also have a lot of experience in publication extensively at UPenn, also here at the New York Proton Center. So we are very lucky to have both of them here to give us the discussion about in the operational practical aspect of how to integration of the SDX system into the center, and basically it's a functional aspect of how to use the system in the facility. So with that said, I would turn the screen and the speaker to Dr. Chhabra and Dr. Lin.
Thanks, Dr. Giap. Dr. Lin and I want to kind of welcome everyone on this call for taking the time to kind of join us today. Obviously, thank you to DYN'R for giving us the opportunity to give you this talk. We wanted to do something a little bit different and sort of do a little bit of a tag team presentation around actually the integration of the SDX system, which we heavily utilize here at the New York Proton Center, and just sort of our thoughts around it, as well as how we sort of integrated it deeply into our clinical workflow. So as Dr. Giap mentioned, I'm Dr. Arpit Chhabra. I'm a radiation oncologist here at the New York Proton Center, specialized in basic skull and spinal tumors, as well as GI malignancies, for which I utilize the SDX system, in addition to sort of the clinical responsibilities, work on the side of education and training for the New York Proton Center here. And we have Dr. Haibo Lin.
Yeah, I'm Haibo. Thank you very much for everyone to attend this session. We will try to share some experiences about SDX in our clinic, and how regarding for device selection, regarding some validation QAs, and also some challenges we have.
Perfect. Thanks, Dr. Lin. And so as Dr. Lin mentioned, we'll kind of go through these high-level topics today. Again, please feel free to put in questions that you might have into the chat. We'll be happy to sort of answer them towards the end of it. But without further ado, we'll sort of jump into the talk itself. So just a little bit of a high-level overview about the center. Obviously, for those who were already on the call, they were able to sort of watch the video to some degree and get a sense of what the center looks like. But in essence, the New York Proton Center is really the only proton center in the state of New York. And really, it's the only proton center to date that is a consortium center with three major leading academic partners: Montefiore, Memorial Sloan Kettering, and Mount Sinai. We began treatments in August of 2019, and as Dr. Lin will show in one of his slides, you'll kind of see how quickly our trajectory has gone from August of 2019. But essentially, behind the curtains in terms of the center itself, what you'll notice is we are a variant probeam center. We have 4 treatment rooms, 3 gantries, as you'll see in the slide here, and 1 fixed beam room, as well as 1 dedicated research room for which we have complete flash capability, and for obviously flash research, which is ongoing at this point. So you can kind of get a sense of what the center itself looks like on the right there. Again, as alluded to, this is a variant probeam center. We have ramped up very quickly, treating about 100 patients a day at this point, many of whom for whom we do utilize the SDX system. And we'll kind of talk through a little bit about how we best select those patients. But in addition to obviously advanced motion management abilities that we have, we also obviously utilize the most state-of-the-art proton technology with pencil beam scanning in all of our treatment rooms. And that is utilized with, again, having complete high quality CBCT and KB imaging in all of our gantry rooms. You can kind of see a little bit about sort of the layout with respect to treatment planning systems, electronic medical systems, obviously ancillary technologies such as CTs, PET, and MR, but certainly we'll sort of talk mostly about SDX obviously today. And sort of before we talk about SDX, I think one of the things that I wanted to lay the groundwork for to level set is just, there may be those on the call who may not be as familiar with proton therapy or even pencil beam scanning proton therapy, which is really the modern form of using proton therapy. And I just want to kind of describe to you what pencil beam scanning technology is. In essence, the way that PBS sort of delivers dose to the intended target is you're essentially taking a beam which you're directing using steering magnets and delivering treatment from the highest energy to the lowest energy, obviously the distal to the most proximal portion of the tumor in a layer by layer fashion, as you're sort of seeing here in the picture. And those magnets essentially are steering this beam line to, again, be able to sort of dose paint across the entirety of the tumor. The layer switching time is very quick, under a second, and you're continuously doing this process, as you're seeing here in the slides, until you've fully got complete conformality, both at the distal and the proximal end of your intended prescription. And that sort of, in a very high level, very simplistic fashion, really sort of describes how dose painting and spot scanning delivery actually occurs. Again, to kind of highlight what this looks like, if you see the bottom slide there, you can get an idea of essentially how spot scanning is delivering the dose, but also why spot scanning pencil beam technology is the most state-of-the-art technology at this point from the standpoint of proton therapy delivery. When you compare it to older technologies such as passive scattering, it allows really not only the utilization of the Bragg peak phenomenon and the distal conformality, but also these days with proximal conformality, which is really essential to make sure you obviously you're sparing organs at risk, not only distal to where your beam direction is, but also proximally as much as you possibly can. And I think while pictures can really speak volumes, I think videos speak even more volumes. And this is, again, just another representation of how dose painting proton therapy is delivered. As you can see here, this is very simplistic, obviously, from the fact that we're only using one beam going left to rightward, treating this right lower lobe tumor. But you can kind of get a sense of how the dose is sort of painted across from the distal end here across the entirety of the tumor. And the reason I wanted to sort of highlight these pictures and these slides in this video is essentially to show that, as you can see, spot scanning proton therapy is very, very precise in terms of its delivery. And given this increased precision of spot scanning proton therapy, it's even more imperative than it ever has been in the field of radiation oncology to manage motion and obviously moving targets. And while the pictorial below, as you can see here, is sort of an extreme example of what we call the interplay effect with PBS proton therapy, I think it's very illustrative of why motion management is important, and obviously sets this foundation for why.
We're just going to wait for a few more physicians to join us.
So I think, sort of sets the stage for why we utilize SDX and obviously why we utilize breath hold here at NYPC. And obviously, as you can see here, while this is sort of a nominal plan that one may sort of plan and intend to deliver in terms of where the spots should be positioned to treat such a target, what you can see here is obviously if the target is moving in the opposite direction from where the current beam line is delivering its spots, you theoretically could entirely miss the target, though in reality, obviously, this never occurs because we do manage around this. And really, as you can see, why we need to manage around it is really to ensure two ultimate goals are achieved, and that's really the integrity of tumor control, obviously delivering the dose that you intend to, but then also minimizing dose to organs at risk. And not only does protons do that very well, but obviously reducing your overall treatment volume by limiting the motion of the target itself will further allow you to minimize dose to your surrounding normal structures. And there's obviously many ways to do motion mitigation. Certainly, breath hold is not the only way, and there's sort of 5 many other ways that are listed here. I've highlighted in the box sort of 4 of the strategies we tend to utilize at NYPC. Obviously, breath hold and SDX being one of the many important modalities that we use here. And I want to kind of highlight that system here in this slide. Obviously, this is a busy slide, and I apologize for that, but just to kind of give you a high-level overview of what the system itself sort of entails. And I think the major features that I'm going to highlight in the next slide, that really from the patient's perspective, what they're seeing is number 2 and really number 4. Number 2 being sort of the goggles that the patient wears as they're sort of utilizing the device, so they're knowing what their breathing cycle looks like and when they're actually appropriately holding their breath at the right levels. But then also similarly, number 4, which is sort of the mouthpiece and the honeycomb device, which actually regulates the airflow when the patient is utilizing this device. And so, again, just kind of hone in a little bit about the patient experience of what the SDX system really is and how it's imperative to us in terms of motion management and breath hold methodology. If you watch this slide, which again, thanks to DYN'R for providing this, really gives you a sense of what the patient is going through, their experience, obviously having this mouthpiece in place, which regulates their breathing cycle, but also then monitors and makes sure there's only one way of directionality in terms of breathing. And through the goggles that they're wearing, they're watching the red line go up and down as they're normally breathing prior to getting into the breath hold modality. And again, that breath hold, when they're taking it in, is intended to get them into that green space. And then they're able to sort of see through the goggles essentially when they're in complete breath hold. And you can see through here, the red lines, they're sort of normal breathing cycle again, once we've dropped out of breath hold purposely and sort of correlate that with, you can see there with the tumor motion, and then obviously halting tumor motion with breath hold in effort to obviously reduce again the organs that need to be irradiated, but also to maintain that integrity of the prescription to the tumor itself. So we'll get into all this into the next few slides, but just want to give you a high-level overview of the system itself. And we've really utilized SDX system, as I was mentioning, really very deeply into our clinical workflow here at the York Proton Center. And it's taken a lot of sort of operationalization of how we've included it into our workflow, into the patient experience, and obviously into the scheduling. In one effort to allow for increased efficiency in terms of scheduling, what we have done in sort of the year and a half, almost 2 years now, of our experience at NYPC is we've found that it's most efficient to dedicate one of our gantry rooms to the SDX system. And I'll show you why that's important. But as you can appreciate, it does take some time to sort of set up the system, both to activate and deactivate the system on a daily basis for each individual patient. And one of the ways of making that more efficient and obviously increasing throughput and comfort level for the therapist in each of the rooms is really to dedicate gantry room 3, which is specific to us, obviously, to just SDX breath hold patients. On top, to layer on top of that in terms of further increase in efficiency, we've also attempted at all times really to try to schedule our SDX patients to be back to back to back to back. As you can kind of see here, taking representation day, which was this past Monday, the following Monday, you can kind of see that we have tried to basically schedule patients who are going to be utilizing SDX consecutive to one another. And each of these time slots, as you can see, is generally about 45 minutes, which is approximately about 15 minutes more than our traditional non-SDX time slots that we utilize for our patients. You can also kind of get a sense from this slide here, in part a little bit about sort of the different disease sites for which we utilize SDX, and as you would rightfully probably assume, it's our breast cases, our liver cases, or GI cases, and our lower thoracic cases. And Dr. Lin will sort of get into more detail about what the percentage breakdown is in one of his future slides. But just want to give you a little bit of a sense of sort of how scheduling occurs to try to increase efficiency in terms of utilizing this modality. One of the other things, if you take a step back, what I've shown you so far is really the scheduling on the treatment side of things. But if you take a step back, obviously to the simulation part of things, SDX really has to be very deeply integrated into the simulation workflow, in part because it's one of the first times that the patient obviously is getting introduced to the system and they've got to get comfortable with the system. The therapist, obviously, and our team have to be comfortable that the patient is going to be an appropriate candidate. And so there's a lot of time also spent at the CT simulation workflow to make sure that we're appropriately utilizing this really advanced modality and technology of motion management. And what you'll see here is what we try to do in effort to maintain, again, efficiency in utilizing the modality is we actually set a SDX training session, which is an hour-long session right before every CT time slot for a patient that we intend to use or we hope to use SDX for. And I'll walk through a little bit about what that sort of introductory or sort of that training session entails in the future slides, but just wanted to kind of, again, highlight to you what this sort of looks like in terms of our schedule. We also do one additional thing even prior to that training session, before the patient even comes on site, is if we know that a physician or a provider is looking to use SDX for one of their patients, we actually will send this brochure, which we've created in collaboration, obviously, with DYN'R and obviously with a lot of work from our internal team, which is an introductory sort of pamphlet for the patients. So they can, again, get a little bit of comfortability in terms of what they're going to see during that training session, what they're going to see during that sort of breath hold simulation day. And we'll kind of, again, go through all the content of this brochure in just a few seconds here, but just want to, again, highlight sort of how we've really deeply incorporated this modality into our workflows. So, once the patient's obviously coming in for the day of simulation, one of the things that we will do is sort of that training session, which I'll show in a few slides. But if we feel that patient is able to appropriately hold their breath, and ideally what we define that as is at least 25-second duration of breath hold 5 to 8 times ideally. And if a patient is able to do that, we then know that we're able to sort of test whether this is a patient for whom we need to utilize SDX. So we haven't even at that point made a decision point about whether it's necessary or not, because a function of that will be dependent on whether there's a lot of motion or not. And so if you, for instance, take our GI and our thoracic disease sites and sort of what our workflow looks like on the day of simulation for, let's say, a liver tumor, for instance, things that we'll do, first of all, once we know that that patient can hold their breath and utilize the system appropriately, is we'll do what's called a mini 4D scan. A mini 4D scan, as you can imagine, is really just to give us a small field of view around the area of where that moving target is, in an effort to determine whether that falls into above or below our threshold of 8 millimeters, which we define as our internal standard for minimal. If the motion on that 4D scan, and generally this 4D CT scan is being done with compression belts in place already, is less than 8 millimeters, we at that time will determine that that patient does not need the SDX component of for their treatments, in part because we feel less than 8 millimeters is relatively minimal motion that doesn't necessarily require the slight increased time that's necessary for treatment delivery with breath hold. However, on the contrary, if the motion at that time with compression is felt to be more than or equal to 8 millimeters, the physicist on site, who's really, again, an integral piece of this whole workflow, will then determine that we are going to do SDX at that point. And at that point, we will again confirm that the patient is fully trained, fully comfortable, able to hold their breath as necessary, and we'll go down the pathway of actually performing an SDX breath hold CT scan, as you'll see there. We always tend to also get a free breathing scan in many instances, again, in part because one of the things we realize is you want to have full visualization of not only the target and the organs at risk, but the device itself, because you want to avoid the risk of collision with your gantry or your snout. And so it becomes imperative to make sure that your field of view is large enough that your dosimetrist and your treatment planning team have that information at their fingertips when they're planning. So similarly, on the breast side, it's a little bit more standardized in terms of not necessarily needing that 4D mini scan, because you're not necessarily using SDX in these situations to limit target motion, but you're doing it in part to try to increase the distance between the heart and obviously your target. And so in these situations, it's a much more streamlined process in which we are doing a DIBH SDX scan as well as a free breathing scan for every single one of our patients who we feel, let's say, for instance, has a left-sided tumor requiring regional nodal irradiation, and one obviously who can hold their breath. And we'll then offline compare how much utility, how much heart sparing, how much lung sparing we're sort of getting utilizing SDX from that standpoint when we're determining whether we're going to treat them in a breath hold fashion or a free breathing fashion. So that's kind of what happens sort of at the simulation time once we know that we're going to be doing SDX and once we're sort of evaluating how much motion is actually occurring. I'm going to take one step back and again highlight sort of that coaching session, and that's that 1 hour time slot that's happening prior to an actual CT simulation occurring, in order to actually determine that a patient, first of all, is comfortable with the goggles, the honeycomb, the mouthpiece, the workflow of the SDX system, but is also actually able to hold their breath so we don't get into an issue sort of at the time of treatment, where obviously they're not able to hold their breath for the course of their radiation treatments. And during this coaching session, what they're essentially seeing is through wearing the goggles, through sort of breathing through that mouthpiece, they're watching sort of obviously their breathing cycle, and they're getting instructed on how much and where to hold their breath such that we're able to create sort of a region of interest, which is representative here by the green bar, which is where they're going to try to hold their breath to every single time as sort of their target inspiration area for their treatments. And you can kind of get a sense here basically from the orange bar how long they can hold their breath within that target area for. And if that's again 25 seconds or more, at least 5 times, ideally more, then we know that that patient is sort of coached appropriately and is an appropriate candidate. And then for them to move on to see if they need SDX, and if they do, then they would be a good candidate to obviously move forward with a breath hold treatment. And the treatment day is obviously going to look very similar. The patient's obviously going to get positioned in the same way they were for the CT simulation, and they're going to be holding their breath, as Dr. Lin will go into a little bit more detail about, obviously into that green bar, into that target of interest. And we do have an added safety feature and a quality assurance feature, which is a gated feature here at NYPC, where if the patient were to fall out of that green bar earlier than the beam is finished delivering, it will actually stop the beam. And Dr. Lin will again talk a little bit about all the quality assurance that's gone into actually being able to have that feature available. But you can kind of get a sense here that this is essentially what it looks like for the patient on the day of their treatment, in which they're usually trying to hold their breath about 15 or 20 times, again, which is a function, again, of how many beams we're using, how large the target is, how long the overall treatment will be. But just wanted to kind of give you a high-level overview of sort of, you can see how deeply the SDX system is part of our workflow over the past 2 years that we've sort of been utilizing it. And a lot of people here have a lot of experience utilizing the system, both from our experience here in New York, but also prior to this. And we really do feel there's a lot of utility, and it helps us a lot for many of our patients. So just hopefully it's given you a good sense of how we've integrated it into our system. So with that, I'll pass it to Dr. Lin to talk a little bit about the physics perspective of the SDX system.
Thank you, Dr. Chhabra. So I will take over in the next 20 minutes. I'm going to try to go through some our experiences and start with the patient treated with SDX, and then present you some validations and quality assurance program that implemented at NYPC, and then talk a little bit about applications and challenges. So this is the patient statistic for NYPC. On the bottom shows you the patient statistic for August 2021, which is last month, and also by August 2021. Now, overall, we treated 1,472 patients, and we started August 2019, so we treat around 151 patients in 2019 and 702 patients in 2020. So far in 2021, we already treat 619 patients. So I believe we will treat more patients than 2020. And among all those patients, around 37% patient has priority. It's relatively higher than other proton centers, mainly because we have this consortium mechanism that often there are challenge cases that for the photon side they will refer to the proton, and we'll take care of that. And among all the treatment, around 17.3% patient has at least one adaptive treatment during the treatment courses. And around 10% of patient has a SBRT treatment. And also among all those, around 1,500 patients, we have 10% patient actually received treatment with SDX. And look at the total patient statistic. The big 3 sites are head and neck, pediatric, and CNS, basically are not involving SDX process. And Dr. Chhabra already mentioned that we basically treat the thoracic, lung, breast, and GI with SDX. And overall, you can see the percentage is around 23% of patients. Among this 23% patient, we have around 10% of patients actually receive SDX treatment. So here shows you the breakdown about this 152 patient treated with SDX. And a little bit surprise, I think, to the audience. Now, the biggest portion is for the breast. The reason I say it's surprise because I believe there are quite some publications talk about the benefit of DIBH for proton therapy. Now, in the photon world, we understand when you do breast hold, you use tangential beam to treat the target. The separation between your chest wall and heart basically can bring the dosimetric benefit. But with the protons, if we use the anterior and infrared beam, and lung in the middle basically won't be able to effectively stop the proton, and you assume that the dosimetric benefit is very minimal. And later I have a slide to show you. Maybe I can give you some background why we started with breast and where we are and what the next step. And the other thing I want to point out is 1/3 of patient actually is a GI patient, liver, mainly liver. We only treat a couple pancreatic cancer patient. And besides that, when the lung patient, especially the disease on the low lobe of the lung, and patient has relatively good lung function, we also use SDX to treat them to immobilize the target volume. And besides these three major sites, we also treat some mediastinal and also some lymphoma patient with SDX devices. So we are a relatively new center, so we experienced the process to decide what equipment to use and select a device for DIBH. Luckily, I had quite some experiences, in my previous center regarding to, breast hold devices. I basically used the SDX for about 6-7 years, and during this 6-7 years period of time, a physician from other institution joined my previous center and strongly recommend another devices. So I get a chance to bring that device into the center and evaluate and also introduce that to photon SBRT treatment. So I quite, get quite understanding about pros and cons of both devices. And when we come to the point that decide, okay, we need to select the device for DIBH, basically there's no struggling. I just went to SDX. A couple of reasons. Number one, I personally experienced both devices. I feel like voluntarily breast hold is more comfortable for general users. You feel you have fully control about your breath. So that I think patient will have better experience on that. And secondly, SDX will monitor the absolute lung volume that basically can maintain high reproducibility and high accuracy about target position, anatomy, organ position when you do breast hold again. And also the system is highly integrated and it's basically placed on the trolley and you can move around. We have, as Dr. Chhabra mentioned, we have 3 CTs, we have 4 treatment rooms. And although we have dedicated treatment room for breast hold, but we still need more around, share some equipment sometimes. So this high integrity is very helpful. And the other thing is this video glass and help patient understand what they are doing. And it helps for the training, help the patient to more collaborative during the treatment time and try to maintain high quality and high reproducibility. The other thing is that, the system provides a gating interface with the probing system. So we started with manual mode. And in my previous center, we basically always use manual mode. There's no issue with that. And from physics point of view, manual mode, it really depends on how concentrate the group to the patient, monitor the patient, monitor the breathing pattern. So depending on, if patient drop off from the gating window and therapist manually turn off the beam. So that introduced some uncertainty there. But if this process can be automatic, can use this gating interface, I think it's improved the performance. So those are the reasons that we select. I think overall, all the features provided by SDX meet our requirement or our need for breast hold. So that's why we decided to select this system. So talk about auto gating. The SDX system require first you have 3 consecutive regular breath pattern. That means over here, and then give it the green light. See, okay, you can start the breath hold, and that will indicate on the glasses. The patient will see that. And before that, you can request the beam, and then you can even see beam on, because the interface will control the beam. And before the patient reach to the gating window, the beam will be on hold, and until it receives a signal from SDX system, see, okay, patient reach to the gating window, we can have a beam on. Generally, the communication is around 1 millisecond. So after that, the beam will turn on, and depending on how long the patient can hold, and then as soon as the patient drop off from this gating window, it's also around 1 millisecond, the beam will get on hold. So when we introduced this auto gating into our clinic, we did validation, and we did experience some challenges here, mainly because some patients can drop the breath very sharply because they already hold, and they really wait for you to give them green light. See, I can stop breath hold, and some patients really drop really fast here, and cause an error called the overflow. And when it happened at the beginning, when we initially test this auto gating module, and it turned out that when the patient drop off this window, the system will not hold the beam. Ideally, it should hold the beam and wait for a rest, and then patient come back for the gating window, and the beam will automatically turn on. But when we have this at the beginning, when we have this overflow error, the beam will drop, but not on hold. It basically drop out, and you need to request again. That basically introduced some complications. And working with Varian and also DYN'R, and basically worked out and fixed this problem by adjusted the software and some Varian sides, just some hardware parameters. So let me show you the validations, and that at the beginning we also try to stress the system and play some videos provided by our physicist Chin, who did the validation. So basically, when you hold the beam, you'll see the beam automatically turn on. You drop off. Yep, the beam basically is on hold. Then you do 3 consecutive regular breaths, and you get green light, you turn on, and then you can reach to the gating window again. Then the system will automatically turn on the beam. And if you drop off, the beam will get on hold. Then you do another rest, and then consecutive 3 breathing, and the beam will turn on again. Yeah, this is a simulate that you have very sharp drop off from the gating window, and SDX system will basically show the overflow errors. And at the beginning, the proton beam will drop off, but now you can, after the fix, even you stress the system very hardly, the beam will automatically turn on. Yeah, this is just a demonstration, how this auto gating system is working. I think therapists really like it, and they basically don't need to monitor the SDX screen too much, very much. They just need to focus on the monitor of in-room monitor to watch the patient. So, with this auto gating available, we start to validate them. We basically repeat some of the patient-specific QAs with this gating module. And here shows you, without gating, that means the beam delivery just one time and no interruptions, and what is the gamma passing rate. And then we repeated two times for each of the measurement with auto gating and randomly stop in the middle of the beam and then resume. And I believe the interruption is around 4 to 5 times. And also we did another measurement with manual mode. That means we manually pause the beam and then drop off and did another measurement. So here it shows you, the results is very consistent compared with without gating. And also the manual mode most of the manual mode has a slightly higher passing rate than the auto gating. It's not clinical significant, but very slightly high. So, and this basically the data show us that the consistency regarding for those calculations using this gating module, and gave the clinical team very high confidence to use this system for patient treatment. So regarding to quality assurance, we follow the recommendations from the vendors to do routine SDX daily QA. And in the meanwhile, we built this gating modules into our machine daily QA. This is specific for treatment room 3. We dedicated for the breast-hold patient. And here shows you the phantom and also the matrix PD devices. And here shows you those patterns that for our daily QA. We basically use the QA syringe and reach to the gating window and as indicated in the previous video, and then pause in the middle for a couple times to ensure this gating function actually is still working accurately. Besides the daily QA, also we built this into our monthly machine QA as well. We check the SDX equipment connectivities. One of the reasons is that generally the daily QA for SDX is carried out by therapists, and for monthly QA we want Physicist involved, have an independent check about the SDX equipment quality and the connectivities. And in the meanwhile, this is the absolute dose measurement with ionization for every month for a specific beam. And here shows you the deviation, with and without gating, and how much difference you expect. And basically you can see it's very minimum. So regarding to the workflow, Dr. Chhabra already mentioned, and this is just a summary of flowchart. And when the patient has a SDX order from simulation order, most patients will directly go to simulation scheduling, and that means 1 hour SDX coaching schedule, and then simulation. During the coaching session, if patient can tolerate well with SDX, I think we have criteria, but really, for example, if patient really pass 5 times 25 seconds and really struggling, and after that, we also allow them to do DIBH. Those are the lessons that we learned. I think it's really important during this coaching session, we can have, besides this criteria, we have some, kind of evaluation or judgment to see if patient really can do better, or really patient condition is going down, and we probably should not put patient in the DIBH, because we did see that they passed the criteria and did a simulation, but when patient come for the treatment, they are really struggling. That's one thing. my point is, for patient selection for DIBH at this step, actually it's critical. It may decide, your treatment efficiency is high or low. And after that, depending on the treatment site, and if it's a breast patient, we will do DIBH scan and free breathing CT scan. And the physicist will evaluate the anatomies and decide, okay, if we want to treat with DIBH or free breathing. If it's a GI or lung patient, we will first do a mini 4D CT scan and check the patient motion, especially around diaphragm area, if target is close to there, and see the motion amplitude. And if less than 8 millimeter, we don't do DIBH scan, just do a full 4D CT and then plan with that. And if it's more than 8 millimeter, other motion mitigation method may not be as effective as DIBH, then we will do a full scan with DIBH. At the same time, do some mini scans, ensure there's a high reproducibility. And if it's the other side of it, like some lymphoma patient, and if generally the target volume is relatively large and also extend from very superior all the way down to diaphragm, and for that kind of target, the motion across the target is not uniform. So the best solution is immobilize the target volume and treat it. So DIBH actually is a better solution in that sense, which is scan the patient with DIBH. Once all the DIBH scan is collected, and then we will push the image to the planning team and let them contour, and based on target and do robust optimization and robust evaluation. And during treatment, we do KV and column CT to evaluate reproducibility, just based on imaging fusion and registration. And then patient will receive gated treatment. During the treatment courses, we also repeat the simulation, evaluate the dosimetry differences associated with anatomy changes, and that also include the reproducibility of SDX. Yeah, here's summarized, the reproducibility is one of the key goals for high quality radiotherapy. And we basically, especially physics team, are choosing this goal from different angles. For SDX, this is also a key factor because we assume that the target is relatively static when we do at DIBH. But really, during CT scan period of time, you can study this reproducibility through mini scans. The variation basically comes from the gating window has some waste, and typically 10% there. Also, we see because the patient has this video goggles, and they can visualize where the gating window is and where the breath hold level is, and they sometimes on purpose adjust their breath hold level, even they already reached to the window. They adjust to the middle of the gating window. They think that's better. That's perfect. So basically, I would say it's maybe not necessary, and this has to be emphasized, where this information has to be passed to the patient during the coaching session. Let me better understanding the reproducibility actually is better than just I'll just move to the middle of the gating window. As I mentioned, the KV, we do the KV to the bony and then move to the column CT. And this shift basically also a good indicator about the reproducibility. It's just the quality of patient initial setup. And often based on the column CT, we'll do some fine tune about soft tissue alignment before we treat the patient. The biweekly or weekly verification CT is very common across the Proton Center, may not common in the photon world. We basically review the dosimetric impact by forward calculate those on those ULCTs. And often if we are interested in the reproducibility of SDX itself, we can just register with the bony anatomy and really look at the anatomy changes. So often we see the reproducibility is within 5 millimeter, and we barely see more than that. and most of the cases is 1 to 3 millimeter. Here shows you a planning CT for a liver case that has the 2 target CT indicated there, and for 5-day treatment, you can see the reproducibility. And often we see very good. Not saying it's not possible to have a large deviation. We did see some liver patient, significant differences on the dome area between simulation and first-day treatment. I don't remember it's necessary from SDX, but during simulation, when the patient just come in first time to the center to do this CT scan, often patients really nervous, upset, and that can be some factors that the patients end up to be scanned with very unique anatomy, and end up when the patient come into the treatment, and the patient actually has a different patterns for breathing, and the solution is depending on you can quantify the differences, how much it impact the dosimetry depending on your beam angle. You may treat the patient, may just end up at the imaging step, and then rescan the patient and replan the patient. So physicist and physician has to make the clinical decision based on individual cases. So I'll come to the breast treatment with SDX. Our first patient actually is a breast treatment. The patient end up have very unique kind of geometry, and similar to the case I show here. And on the right side is a free breathing, and you can see the patient heart actually is next to the chest wall. And then physician just ask a question: can we do a DIBH scan? And we want to see what the difference is, how much we can gain from it. And then we did the DIBH scan, which is on the left side. You can clearly see there's a large separation between chest wall and heart with the DIBH, and also the lung volume actually increased a lot because of this breast hold. And end up we plan and treat with the DIBH scans, and physician feel like this is a good case, show that the DIBH can help, not just only for photon case, and in some proton case it's also helpful. So that's basically the background and history why we started with the breast DIBH, and from that point we started accumulate more and more cases. Especially we are not really busy at that time. We have a lot of slot in the gantry room, so not to really get pressure, so we need to improve efficiency. But right now we are treating close to 100 patients. Now we started to collect all the data that we treated with breast SDX, and hopefully soon we can present some data to the community, and also come up with a criteria for patient selection for left breast with DIBH, and really select the patient who can benefit from it. And here shows you the average treatment time for the patient that we treated with a breast hold. The blue bar shows you the schedule we made for each individual patient. Typically, there are 4 categories, and some patients schedule is 30 minutes, some schedule 45, 60, and 75 minutes. So the red bar basically shows you the lung patient. If you look at those data, and you can tell for lung patient, no matter with how long we schedule for the treatment. Here I want to point out, the schedule time is depending on how complicated or how the plans may generate it. Number one, depending on the total MU of a plan. Number two, depending on how many fields are planned. And also, does patient has other complication factors like, multiple ice centers or couch cake, or patients planned with a low dose rate B model. This is specific for a variant system. So if it's more complicated. We schedule for 60 minutes or 75 minutes. And if you look at the 3 red bars, we can make a conclusion, no matter how complicated for lung cases, and we can treat the patient with around 40 minutes. So the scheduling basically can be like 35 to 40 minutes. That's reasonable for a whole lung patient. If we look at the breast case, which is the orange bar, for patient 45 and 60 minutes schedule, we roughly can finish the treatment around 45 to 50 minutes. And the 75 minutes patient, we only treat 4 patients. We only have 4 treatment. I think this patient is bilateral breast, which is a huge target volume, and planned with probably 3 or 4 beams, and really prolong the treatment time, and that's why end up to be like really long treatment time. And now we end up we don't treat any bilateral, only left breast, and also based on the patient anatomy to select the patient. For liver patient, which is a green bar, generally is scheduled up to 60 minutes, and we do see some patients struggling, especially for 2 reasons. Number one is patient really not in a good condition. They cannot hold their breath long enough, and they need a rest in between breath hold for a long time. That basically hold the beam and prolong the treatment time. The other factor is we have this kind of like a beam model, and as I mentioned, we can adjust the dose rate. With the Eclipse, we can only create the individual model to decide the minimum MU of the plant, which is the minimum MU of each layer, or decide how fast that layer can be delivered. In other words, the dose rate of the beam. So at the beginning, we started with a low MU, minimum MU, and end up to be very, very slow dose rate. So that contributed a lot of patients in 60 minutes. But now with the relative high MU model, and the dose rate is high and delivery is faster. So roughly 45 minutes for liver, or some complicated cases, probably close to 15 minutes. That's basically just our own institution experiences. We put data from ARIO for analysis. Here, the data doesn't include the time you bring the patient in and bring the patient out. So the time basically start when the plant is loaded on the machine to the endpoint is the last the beam delivery ends. So just for your reference. Challenges, I mentioned there's overflow errors, and we already resolved working with vendors. Currently, we didn't see this anymore. Other common SDX device issues are mainly associated with connectivity and communications between device and the computers. So that's why we had some redundancy. We always has the laptop and desktop as a backup, and whenever the communication is lost or we can't establish communication, we always have a backup solution. The other things, the video goggle display, it require specific configurations regarding to computer resolution. So sometimes the people switch the computer and the resolution will cause you want to be able to synchronize the video glass. So that's something that the staff member need to get good training and can quickly resolve those issues. And also, user accumulated experiences, and on the other side, the vendor actually provide very good training on this troubleshooting, and also their online support is very good, and you can always call them and get immediate support. During COVID period of time, we actually introduced extra steps to clean the device. So next slide is my last slide. I just want to show you what we did. And the other thing, associated with this device is a lot of people are, interested in exhale, breath hold, or free breathing gated treatment. Because you have interface, I think vendor can definitely think about and working with other users and to develop something which can benefit more patients. If they cannot really hold their breath. This last slide basically shows you, during COVID period of time, vendor make recommendations. So we need to clean the device immediately after each use. And although the system actually built in with this BVF bacterial barrel filters, which can filter out this bacteria, but really on the device, between patient, beyond this, we also have a shared part, which is this metal tube, breathing tube, and what the vendor recommended is after each use, of course, you need to replace this filters, and also you need to clean this tube and submerge this tube into this high-grade disinfectant for around 20 minutes. Since we are quite busy with SDX, so we purchased 2 more breathing tube, so we can replace and clean it, and then we always have a system we can immediately use for next patient. Of course, another step is all the SDX patients need to get a COVID test before they come for the simulation. In summary, this DIBH is an important tool for proton therapy to treat the moving target, and uses DIBH can help to manage the motion associated uncertainties. And SDX provide a user-friendly platform, especially the goggle and also voluntarily breath hold. A lot of patients are really comfortable with the system. As a physicist, we need to do comprehensive validations and also implement reasonable quality assurances program to monitor the system and ensure the functionality and liabilities. Patient coaching and patient selection protocol is important. That basically decide if patient can do well during the breath hold, and also that also decide can you efficiently treat the patient with breath hold. And also you need 3D images, for example, count beam CT and the repeating CT to really monitor the reproducibilities of breath hold for each individual cases. Thank you very much, and we can answer questions if you have.
Okay, excellent presentation, Giap, Arpit, and Haibo. There are quite a few questions, so I will pick some questions that are more